Hello. In today's lesson, we will compare normal and abnormal findings in a three-vessel trachea view. Here is a stick and mode of that. Here's a three-vessel trachea view. I just wanted to show you. This is one of a new technology that is on our GE machines. So it's just called or known as a stick and mode. So I just wanted to give an example of that, but let's get started. All right. So why are the three-vessel views and the three-vessel trachea views considered effective screening views in the detection of congenital heart disease? So I created a checklist, and there are four very important sections for the three-vessel view and trachea view. It allows a comprehensive assessment of all the outflows, as well as the aortic arch, our upper middle spinal structures, and it gives clues to ductal dependent lesions, which are essential for prenatal detection. Now, how to achieve this view? It starts off with a simple sweep. A simple sweep starting from your four-chamber view. You'll see your LVOT, your RVOT, your three-vessel view, your three-vessel trachea view, and then your upper mediastinal structures, which includes the brachiocephalic vein, the left brachiocephalic vein, and the thymus. Now, we do achieve this sweep in a grayscale as well as in color to document the flow. I'll show you again. Start with the situs, four-chamber, LVOT. I list all of the steps within the sweep. Once you're inside the heart, all of these different clips that you're seeing are within a hairline from one another. Perfect. All right, so let's get started here. Okay, so we're going to go over a normal checklist. Now, a three-vessel view and a three-vessel trachea view are two different views, as you see. I remember initially when I first was introduced to this view, I thought they were the same, but they are indeed not. You can clearly see the three-vessel view above is the cross sections where you can see right SVC, aorta, and pulmonary. You're able to show that they are in descendant order from the largest to the smallest. Your largest being the pulmonary artery, and then your smallest at the right SVC. And they should go into that order. The aorta is just slightly smaller than your pulmonary artery. Okay. Now for your three-vessel trachea view, it's more where you see the cross-section of the ductal arch and the transverse aortic arch, where they converge into a V shape. You see that? Start to come together. Now, what's important in this angle view, you definitely want to see your trachea. You see it's posterior. The vessels are to the left of the trachea. Notice that, and anterior to the spine. Okay. Now here, once again, is showing that V-shaped conversion of the ductal arch and aortic arch. I do want to point out that your pulmonary artery will join your ductus arteriosus at the end, and your aorta will join the aortic isthmus. That's where the V joins, heading towards the descendant aorta. Now, why is color flow important? You want to show that there is forward flow in both vessels, which are demonstrated here. So that flow should be heading towards the fetus spine. Okay. All right, now we're going to just go over some normal structures that are seen within your three-vessel trachea view. Starting off with the azygos vein. Your azygos vein is seen draining into the SVC occasionally. If you have your settings at a lower scale, you will see the azygos vein. So this is a normal structure seen in your three-vessel trachea view. You can see that. Now, because it's draining into the SVC, you're going to see that the flow is opposite of what you're seeing in your great vessels. Okay. All right. Another known normal structure is the left subclavian artery. The left subclavian artery is the third and final branch off the aortic arch. So occasionally at a lower color scale, you will see your subclavian artery branching off the aorta. This is not to be alarmed. This is a normal structure seen. You can see that there. And this too, blood flow is different because it's heading towards the fetus left shoulder. So opposite of your great vessels. All right. So when we get into our top of our sweep, this is going towards the fetus head. You're going to see your left brachiocephalic vein. The left brachiocephalic vein will be present. The flow is going to be opposite direction of the aorta because it is flowing differently. Let's see an example of that. So this is simply just a cranial oblique plane, which you can see there, that's coursing superior and horizontal above the aorta. Okay, it's going to be right below your thymus gland. And this is draining into the right SVC, which is why the blood flow is different from your great vessels. Another name for the left brachiocephalic vein is a nominate vein. Okay, so what's important about this structure is that the flow is opposite of the aorta. It's flowing from left to right because it is draining into the right SVC. Okay, so now we're going to look into some structures of our thymus gland. So our thymus is very important to visualize. Not only that it's there, but you want to recognize that it is normal size. So this is a classic picture known as the thigh box. And the reason why it's known as the thigh box, you can see the mammary arteries. You see that? So it's creating like a box illusion around the thymus gland. Notice the left brachiocephalic vein, which is posterior. And notice that I keep pointing out that all of this is demonstrated at a lower color scale. So it's really important because without your lower settings, you won't see these structures. So I demonstrated here. I have 3 examples of the thigh box. And pointing at the top, you see at settings 11 and 14, we're able to see the mammary arteries at the low setting. When I increase the scale to 78, notice it's not there. Of course, yeah, we can still see the thymus gland is there, but in order to achieve the thigh box, the classic thigh box picture, you want to lower your color scale to demonstrate the mammary arteries. Okay. All right. So why is the thymus gland important to see? Researchers actually have found that in fetuses that have a microdeletion of 22q, they have a smaller thymus gland or even absent thymus gland. And so it's really important to demonstrate that you are seeing that. Now you can do the thymic to thoracic ratio measurement. I honestly, this just opinion of me, is that you can visualize the difference even without the measurement, which you can see here when they're side by side. Clearly, you can see the difference between the two. Here's the normal. There's clear separation from the vessel to the chest wall, where there's not as much separation seen with the deletion 22q. Now, why is this important? I did some further research and found that chromosome 22 is responsible for quite a few things during fetal development. And one of the structures that the chromosome 22 is responsible for forming during development is the thymus gland. And not only just the thymus gland, it's also responsible for the conotruncal region in the fetus heart, as well as some facial structures, one being the palate and other facial characteristics, and countless more. So if we notice a thymus gland on the smaller side or absent, especially when it's correlated with a conotruncal defect or a cleft palate, we suspect that there is a microdeletion of the chromosome 22. So very important to know. Okay, so now we're going to start discussing some abnormal findings. Okay, so now let's go here. Now, there are several different presentations of an abnormal three-vessel view and three-vessel trachea view. I decided to include all the structures that are seen within the view, and then I wanted to show what could go wrong. Okay, so starting with your pulmonary and your aorta, your great vessels, they typically will show either on grayscale narrowness, absent, dilated, or displaced. And in the color scale, you'll either see retrograde flow, turbulent flow, or absent, no flow at all. Now, in your superior vena cava, you'll see on grayscale can either be absent, dilated, or bilateral. Left brachiocephalic will either be absent or dilated. Thymus gland, absent or small. Okay, so when we're looking at a three-vessel trachea view, this is what we're looking at. We're determining if there is a abnormal vessel size, how many vessels we're seeing, how's the alignment. So are we in descendant aorta order? Are we seeing the vessels pulmonary, aorta, SVC? Are they out of order? So that's the vessel alignment. And what is the color pattern? Is the pattern normal flow? Okay, so that's what we're going to take a look at a few examples coming up. Now, before we get into our examples, I do want to point out all the different congenital heart diseases that are associated with the abnormal three-vessel view and three-vessel trachea view. All of them are listed here. I did highlight the ductal dependent lesions. These defects are the ones that are essential, mandatory. It could be detrimental to the fetus if we do not catch these prior to delivery. Okay, so I will try to touch on all of these in the next few examples. Okay. All right, so we're going to start with abnormal vessel size. So we're starting with the pulmonary artery. Now, if you come across a narrow or absent pulmonary artery, you want to suspect that there is some type of RVOT obstruction. Okay. Now, when you suspect that there is a RVOT obstruction, that's usually suggestive of a pulmonary atresia or pulmonary stenosis. Now, here on these two examples, A and B, you see that there is a narrow pulmonary artery, but one has antegrade flow and the other has retrograde flow. Okay. Now, one of these are pulmonary atresia, one of these are pulmonary stenosis. Which is which? Can you tell? Do you know? So that's what we're about to go over. So with pulmonary stenosis, you're going to have a narrow PA as we see, but you're going to see integrate flow in your pulmonary stenosis cases. Now, in the case where there is no flow present or there's a backflow, you're going to see that in pulmonary atresia. So you're going to see the retrograde flow in those cases. And that's how you tell the difference between the two. Now, as you recall, pulmonary atresia was on our ductal dependent lesion list. So this is the one that we need to catch all defects, don't get me wrong, but definitely with these ductal dependent lesions, these need to be diagnosed prenatally. And so right away, when you notice that there is retrograde flow in your pulmonary artery, we would like to suspect that it is pulmonary atresia. Okay. Now, if you notice here, I listed without VSD, with VSD. So we take a step further to discuss adductus arteriosus. Adductus arteriosus take on a certain form when there is a VSD present. So if there's a VSD present with pulmonary atresia, you're going to notice that your ductus arteriosus will be spiral or tortuous, and you will see reversal flow or absent flow in the ductus arteriosus. Okay. Now, if there's no VSD present, your ductus arteriosus is straight, but it will still have reversal flow. So color is the key in these diagnoses. Okay, so I have an example here I wanted to show you first. So take a look right away. Right away, we see aorta seems to be enlarged, especially compared to the pulmonary artery. So right away, we see that there is a abnormal vessel size. Pulmonary artery should be larger than the aorta being slightly smaller. There is some reversing happening. And just to take a step further, there is a large VSD. I'm trying to see if we can see it in that clip, but there is a VSD present. Okay. Okay. So, yes, the pulmonary artery did have retrograde flow. And to take a step further, there was a tortuous ductus arteriosus. And so, from what we just learned, this is pulmonary atresia, and it has a VSD present. And why is that? Because we noticed the retrograde flow as well as the ductus arteriosus being tortuous. And I can show you that again. You can kind of see it right there. It's a short clip, but you can kind of see the ductus arteriosus. It's like spiraling. Okay. All right. So yeah, so this was a case of double outlet right pulmonary atresia with VSD present. Okay. So what about cases where there is enlargement of both the pulmonary artery and the aorta? Okay. So in the cases where you'll see like a slight enlargement of those vessels, it's usually due to a thickening, bulging of the valve leaflets during both systole and distally. So there's a thick leaflet in both the pulmonary and aorta, and you may have some post-stenotic dilation. So that's where that enlargement comes into play. Now here you can see the enlargement of the pulmonary artery in this example A. And then you can see also in the aortic or ascending aorta in this example here on this side B. Okay, so there's some post-stenotic dilation. We still have forward flow. There's still some integrate flow, but what are you noticing? There's some alicin, some turbulence. You know, this goes back to like our physics where there's like a stenosis, and right after the stenosis, there's like turbulence right after that obstruction. So that's what you're seeing here. So there's a thickened leaflet. And so blood flow is still going through, but it's just some narrowing. So it's still just narrow vessel, but then you'll see all the turbulence post the obstruction. And that's what's been demonstrated. Okay, so this is different from the atresia. Atresia just has retrograde flow, no forward flow seen in atresia. Okay, now to take a step further, for our post-stenotic dilations, once again, we'll see turbulence and integrate flow, but to take a step further, you're going to see increased pulse systolic velocities. And I'm talking in over 200 velocities, very high increase. So this is just like a confirmation to this diagnosis. Okay. All right. Now here's an example of a ductus arteriosus aneurysm that I've seen. Notice how increased that is. You see the turbulence S shape. So this is an example of ductus arteriosus aneurysm. All right, so let's talk a little about this one. Okay, so on grayscale, the ductus arteriosus aneurysm will show a dilated ductus arteriosus. You'll see that it's tortuous. You see that? It has an S configuration. And then on color Doppler, you're going to notice the allicin. Okay. Even appears to be some narrowness here. So that explains the turbulence too. Okay. And I wanted to show you actually back at the clip, you can almost see the narrowness right here, causing that turbulent flow below that obstruction. You can see it right there. Okay. All right. Now, what are some reasons to why we will see an enlargement of the SVC? We all know from our normal, SVC is the smallest of the three vessels. So there are some reasons to why it will be enlarged. It's usually due to some increased venous drainage. I have a few examples. So we'll either have an AV brain malformation, vena gallant aneurysm that will cause a dilated SVC, as well as total anomalous pulmonary venous connection, the supracardiac type. Dilated left brachiocephalic vein is draining into the SVC for this particular anomaly. And then the last one here is for interrupted IVC. Left atrial isomerisms, the azygos vein is draining into the SVC and is causing increased drainage. And so these are reasons to why there will be a enlargement of the SVC. Okay. Now we're going to talk about aorta. So if you notice that the ascending aorta in this view is narrow, it's usually due to LVOT obstruction. And so with the LVOT obstruction, just like with pulmonary obstruction, it's suggestive of a few different defects. So with this particular one is aortic coarctation, interrupted aorta, aortic stenosis, hypoplastic left, with or without aortic atresia. So notice in these two particular cases, you have two cases of a narrow aorta. Once again, we have one that has antegrade flow, which is here, and then we have one with retrograde flow. So how are we going to tell the difference? And this is going to be similar to what we saw in the pulmonary artery. Okay, so with aortic coarctation, you're going to see a narrow aorta, which you see here demonstrated. Antegrade flow is present, and with a narrow aortic isthmus. Okay, and with hypoplastic left, with or without atresia, you will notice that the aorta will be narrow, but it will have retrograde flow. This is one of our ductal-dependent lesions, just to point that out. So once again, color is the key. And that's the difference between those two. Color is the key. Okay, so now we're getting to abnormal vessel number. Which types of heart defects are seen when there is an abnormal number of vessels in the three-vessel trachea view? So these are the reasons for 4 vessels being present instead of 3. Persistent left, superior vena cava versus the total anomalous return. And when there is 2 vessels instead of 3, it's due to a conotruncal defect, whether it's without transposition of the great arteries, a common arterial trunk, or a double outlet right. Okay, so we're going to discuss a few. Okay, so here we have 3 vessels. There's 3 vessels present, but is this alignment normal? Take a look. Okay, so no, it's not. This is abnormal alignment because we see SVC, pulmonary artery, and then aorta. And we know with our normal, it should be pulmonary artery is first, then your aorta, then your SVC in descending order. But instead, we're seeing SVC first, and then pulmonary artery and aorta. Now, with this case, this is a classic case of an isolated left SVC. So what happened with this guy, instead, in embryology, just to go back, in embryology, you start off with your right and your left. Now, what happens is that the left is the one that regress and the right persists. So that's why we have the right SVC in our three vessel view. But in isolated left, the regression of the right happened and the left persisted. And this is a case of persistent left SVC. Okay. So let's talk a little more. So I put the normal up here so you can see the right SVC versus left SVC and absent right. Okay. Now we're going to talk about the different drainage that happen in this particular case of the left SVC. Okay. So reminder, normal flow from the left side of the head and neck drains into that left brachiocephalic, which we learned earlier, and then it drains into the right SVC. But what happens when the right SVC is not there? So in this case, both the right and left brachiocephalic vein will drain into that persistent left at the left side of the thorax. So that's what's going on in the cases where the right is absent. So you can see that here. Okay. Now, the coronary sinus is known for the venous drainage into the right atrium. Okay. Now, it should be on all of your diagrams, you see it as like a straw-like structure, I guess you could say. So it's very small, in other words. It's normally 1 to 3 millimeters, okay? Now, in more than 90% of cases, your left SVC drains into the right atrium through your coronary sinus, okay? And because of that drainage happening, it's increased, it's going to cause a dilated coronary sinus. Okay, that's in more than 90% of these left SVC cases. Now, I found an example of when it's called an unroofing that happens with the coronary sinus. So basically, as you look in the diagram here, there is some, I guess you can say, some communication between the coronary sinus and the atria. Okay, so blood is leaking or seeping out of the coronary sinus into the atrium that's causing even more than what is used to as far as volume of blood flow in that atrium. And that causes that left to right shunt of blood flow. Okay, now remember, the foramen ovale, which is in this area, is what causes the right to left shunt. But when you have that increased drainage happening coming from that coronary sinus, it causes the left to right shunt of blood flow. And so then you notice, you see my foramen flap? My foramen flap is now pushed over onto the right side. You can see that in this example. So in normal cases, it should be on your left, but because of this increased blood flow that's happening from the leakage of the coronary sinus, the blood is pushing that foramen flap instead into the right atrium. And this happened in about 8% of cases. Okay. I was lucky enough to see that on a patient of mine. Okay. But in more than 90% of the cases, you're just going to have a dilated coronary sinus. You'll see that dilation of that blood flow going into the right atrium through the coronary sinus. Okay. Now, over 60% of the left SVC cases is going to be associated with another defect, usually is aortic coarctation. In this example here, you see a left SVC associated with the double outlet right and absent right. So if you notice that there's an SVC present, check for other defects that could be aligned with it. Okay. So in this particular example, notice it's only 2 vessels. You see that? You have your LSVC, and then you have this other vessel here. This is not your pulmonary artery in this case. This is the aorta. Where is the pulmonary artery? The pulmonary artery is actually sitting behind the aorta. So a majority of your conotruncal anomalies, the aorta is what's present in the view. And it takes on a rightward convex course, which you're noticing here. The pulmonary artery is actually sitting post behind the aorta, which you can't see it from this angle. Okay. So keep that in mind for your conotruncal anomalies. As we learned, 2 vessels are present. It's usually your aorta and your SVC. In this particular case, it's the left SVC that's present and the absent right. All right. So now we're looking at examples of 4 vessels. We have 4 vessels present in that grayscale. Okay, we just learned about the left SVC that can be involved. Now we see that there is left SVC and a right SVC, right? Okay. Now, the times or the occasions where you will see 4 vessels instead of 3 is usually due to either a persistent left with right SVC present, or in a case where there is total anomalous pulmonary venous connection, supracardiac type 1. So both of these defects will show 4 vessels in your 3-vessel trachea view. How can you tell them apart? And the grayscale is almost impossible. From the 3-vessel trachea view, they look the same. But indeed, one of these is just bilateral SVC, and the other is total anomalous pulmonary venous connection. But it's hard to tell from the grayscale which is which. So how can we tell these 2 apart? It's through the color. It is through the color where we'll be able to differentiate which is which. Okay, so let's start with bilateral SVC. So bilateral SVC, on the grayscale, you're going to see 4 vessels. You'll have an additional vessel to the left of your pulmonary artery. You're also going to have an enlarged coronary sinus, which we know that's involved with your left SVC. Your brachiocephalic vein will be absent. Okay, so keep in mind, during embryology, if your left superior vena cava persists, there will be no brachiocephalic vein. Okay, just keep that in mind. And color Doppler flow will be towards the heart in both the right and left SVC, as you see in the demonstration. Okay. Now with total anomalous pulmonary venous connection, once again, you'll have grayscale 4 vessels. You'll have additional vessel to the left of the pulmonary artery. Your coronary sinus will be normal. Okay. And you will have a brachiocephalic vein because guess what? That 4th vessel is not the persistent left SVC, it's a vertical vein. Okay, so it's a vertical vein with blood flowing opposite of the flow to the right SVC, which you see in the demonstration. Now, what will be prominent? It will be your left brachiocephalic vein. And that's because of all the increased venous drainage coming from this vertical vein. Now, we're going to talk about this a little further, but once again, color is key in these diagnoses. Color is key. Now, let's take a look further. Okay, so we're talking about bilateral SVC, total anomalous. Okay, so with the total anomalous, you see that vertical vein. Now, what's happening? All of your pulmonary veins are connected with this vertical vein. So that's a lot of blood flow happening. So that's what causes this increased drainage through the vertical vein to your brachiocephalic, heading towards the right SVC. So that's why there's increased drainage there. So you're going to notice that dilation in the left brachiocephalic vein. Okay. Now, with your bilateral SVCs, your left brachiocephalic vein is seen in less than 30% cases, but almost always it will be absent. It will be absent. I never thought that I would be using math to help me learn anything because math was not my favorite subject. But in this particular case, if there is a right SVC plus a left SVC, it will equal negative, no, or absent left brachiocephalic vein. So think of the VCs canceling one another out to help you remember this. Okay. All right. So the three vessel trachea view is the ideal view for the diagnosis of our aortic arch anomalies. Okay, and we're going to talk about the right aortic arch. Here is an example of that. Okay, so now we're getting into an abnormal vessel alignment. Okay, so let's go. Okay, so how can you tell the difference between a right aortic arch with a left ductus arteriosus versus a right aortic arch and right ductus arteriosus? How can we tell the difference? Let's let you think about that. And I will go over that. Let's go to the next slide. Okay, so locate your tracheas. This is how you're going to tell the difference between the two. Where's the aorta and the ductal compared to where the trachea is? Okay, now with your right aortic arch and your left ductal, you see it's on the left side, whereas your aorta is on the right to the trachea. Okay, so this is your classic U shape. It's going to create a U shape appearance. So instead of that V configuration that we're used to seeing in a normal convergence, it's going to now create a U shape. Notice the blood flow is still the same, but it's a U shape that you will see. Left ductus, right aortic. Okay, now let's look at right aorta and right ductus. So here you see, we know for normal, a vessel should be to the left of the trachea. But in the case where it's right, you're going to have both vessels to the right of your trachea. It's still going to have a V shape because they're both still connected, still joining with the V, converging over. But instead of being towards the left, it would be to the right of the trachea. Both are to the right. Okay, so that's the difference between the two. All right, now this is one of our most common anomalies of the aorta, the Arsa, and it's fairly new. I would say within the last 5 to 8 years, we've started talking about this guy, Arsa, and they found that Arsa is connected with Down syndrome, and so it's a marker usually, especially if you see it with other ultrasound markers. But what is Arsa? Okay, so first let's talk about normal. So remember our picture from earlier, we saw aortic arch vessels. Okay, so there's 3 vessels, make up the brachiocephalic trunk, your left common carotid, and your left subclavian. Okay, now take a step further with your brachiocephalic trunk. Notice you have your right subclavian artery that branches off, as well as the right common carotid. But in cases with the Arsa, instead, you don't have 3 vessels, you have 4 vessels, which you can see at the top. Okay, so those 4 vessels will consist of the right common carotid, your left common carotid, your left subclavian, and then your aberrant right subclavian artery. Okay, now this can be a tricky diagnosis because if your scale is high, you can possibly miss this guy. Okay, so definitely lower your color scale when you're trying to rule this out, less than 20 in order to properly pick this up. Okay, that's just a tip here. You can see different variations of it. That flow is heading towards the right shoulder. So that's why it's opposite. But very, very important to pick up. Okay. Now, it could be isolated, which almost always it is. And so it's just a known thing, like for surgery. You definitely want to inform the surgeons of this extra vessel if it's there. Okay. All right. Now, some differential diagnosis between the Arsa is the azygos vein. I have seen some texts call an azygos vein an Arsa. So the difference is with azygos drains into the superior vena cava. Look at its location to the trachea. That should help you out as well. Whereas Arsa is connected to your aorta. Okay, so it's connected to the aorta. The Arsa is heading towards the right shoulder, and it will be posterior to your trachea. Okay. All right, now here are some first trimester diagnosis. And what's helpful, the three vessel trachea view, because as we know, in the first trimester, it's really hard to see the heart and its structures. It's really difficult. But the three vessel trachea view takes on an abnormal appearance early on. So usually if there's a diagnosis to be known, especially if it's dealing with any of these, especially you're gonna see it at your three vessel trachea view. You know, the ones that are abnormally seen with the three vessel trachea view will show pretty early on. So in the example, which we've learned earlier, aortic coarctation, it could be seen. With overriding aorta, it can be seen. With our Arsa, it can be seen. And here is a example of a U shape, right aorta and left ductus. It can be seen. So you see, we can pick up these diagnoses pretty early on. This was early. I showed this example where you can see the subclavian artery, and then here you can also pick up the aberrant right subclavian artery. So I just wanted to just see that, where you can see that it is bilateral. Pretty cool to see that. Okay, so I did list the normal up at the top, a three vessel view, a three vessel trachea view, and these are all a few abnormals that I had found in the first trimester in the three vessel trachea view. Okay, so it's very helpful in those diagnoses. Okay, so from all of our slides, right away, we know and seen personally how the three vessel view and three vessel trachea view is a reliable view. It's reliable in detecting the congenital heart defects in the upper mediastinum, our conotruncal anomalies, our aortic arch anomalies. It's effective in determining and detecting aortic stenosis versus aortic atresia, or pulmonary stenosis versus pulmonary atresia. It's very valuable in picking up all of these major and minor anomalies, because the minor anomalies can point out to other major things that is happening. And first and foremost, we can detect abductal dependent lesions prior to delivery. So it's a very valuable view. Okay. And that's it. I do want to point out before we end, reversal. Reversal flow seen in one of our great vessels, which we had saw in the atresias. It's a potential ductal patency dependency in the first hours of life. So it's critical for the newborn. So that's why these views are detrimental for us to pick up. Very essential. It's life-changing to pick these up prior to delivery. I do want to point out that there are other courses in all specialties, not just fetal echo, with Institute of Advanced Medical Education. If you're interested, if you want to join, you can get great discounts if you use my codes here listed. Check it out. I believe you can check out all the different courses that they have prior to joining, but it would be helpful. There's a lot of other courses and webinars throughout the year that you can just run across and just learn. Okay. I want to thank you again for joining me, and I want to wish you a great day. Take care.